Evening and welcome everyone to this evening's event, COVID-19, the what, how and why of the pandemic. This is part of a series of events run by the Royal Society discussing the scientific landscape of the COVID-19 pandemic. These events are all about the scientific response to the pandemic, and I have to say I don't think I have lived through a more fascinating and terrifying scientific moment. We have an amazing panel this evening, and I'm really looking forward to hearing what they've got to say. And we'd also love you to get involved this evening. So we're using an interactive website called Slido, and you can go on there. That will be your hotline to us. If you go to slido.com, slido.com, and use the code hashtag C019. You can also follow the Slido link in the video description, and you can submit questions to the panel and by going to the bottom of the screen, I think. Yes, you can see that in the video description. And you can also upvote your favourite questions, so they'll have a high chance of being answered. And we're going to try and answer as many as possible in the time we have. We also have live captioning available this evening. If you would like to see these, please click on the subtitles closed caption button in the bottom bar. You can also join the conversation on Twitter, and please use the hashtag COVID Science. So who am I? I'm Anjana Ahuja. I'm a science writer, and I'm here because I have written about nothing else except COVID-19 this year. And I'm now going to ask our wonderful speakers to introduce themselves in turn very briefly. And they're going to say who they are and what their professional role has been in this pandemic. So first of all, over to you, Anne.
Hi, I'm Anne Johnson. I'm a professor of infectious disease epidemiology at University College London, and I'm president of the Academy of Medical Sciences. I study how infections spread in populations. And during the pandemic, I've been working with colleagues at the Royal Society on topics like test and trace, the spread of infections in hospital, and also with the Academy of Medical Sciences on how to prepare for a challenging winter and thinking about the resurgence of the virus that we've seen this autumn.
Thank you, Anne. And now, John.
Yeah, I'm John Bell. I'm Regis Professor of Medicine in Oxford, but I'm also the government's advisor on life sciences. And I've been involved in a variety of different components of the response to the pandemic, starting very early on with testing, but also moving on to helping with the epidemiology, managing more recently mass testing, and obviously being involved in the immunology and vaccinology, as I'm an immunologist.
Thank you, John. Nicole.
I'm Nicole Robb. I'm an assistant professor at Warwick Medical School. I'm a virologist, and my lab works on rapid viral diagnostics.
Thank you. And Jeremy.
I'm Jeremy Farrar. I'm head of the Wellcome Trust based in London. My background's as a clinician, spent 18 years living in Vietnam, and since about 1999, focused on emerging infections, and in the last year have been member of the WHO. I'm a chair of the WHO Research and Development Committee for Science, and been on the SAGE Committee for the UK Government and a member of the UK Vaccine Task Force.
Thank you, Jeremy. So we're going to get warmed up by going into our first Slido question. So we'd like to hear what you think about the UK's scientific response to the coronavirus pandemic. Please go to slido.com, enter the hashtag C019. You might need to enter your name. And we would like to ask you in one word, how would you describe the scientific response to the pandemic? And the idea is we're going to get a word cloud that we can use to see what we're all thinking about in terms of the science. And while you're all thinking of your one word, I would like to go to the panelists and ask them one question each, and for it to kind of set the scene. So the question is, what is the one thing that you would love to know about the virus that you don't know yet? So first of all, I'm going to go to Anne.
Well, the thing I'd like to know is how long immunity lasts, whether or not you get the virus naturally or whether as a result of the vaccine. And then if I'm allowed a little extra, I'd also like to know then whether if you do have some degree of immunity and you still can become reinfected, whether that would result in less severe disease, so you would have some lasting protection.
Excellent. And we are getting lots of words coming in. And the big one is rapid, which I suppose shouldn't really surprise us. Shambolic, good, muddled, impressive, incredible. John, what's the one thing you would like to know about the virus that you don't know?
Yeah, so I'm still pretty puzzled by the pathogenesis of this disease. This is it's an extraordinary disease. And in particular, I'm very interested in why elderly people seem to suffer so badly compared to other segments of the population, and what are the aspects of the pathogenesis of the disease, or indeed the immune response that determines that.
Okay, we have more words coming in here. Epic, rushed, unscientific. This might be something that we come back to. Mixed, unreliable. Nicole, what's the one thing you would like to know about the virus that you don't yet know?
I think I'd like to understand a little bit more about exactly where it came from and how it made the jump over to humans. So I think having that kind of knowledge will allow us to be better informed in case it ever happens again.
Okay. And Jeremy, what do you want to know that you don't know?
So it's always tricky to go fourth, and so I would have said what the others said, so I'm gonna have to rethink. What I would like to know is this virus going to throw up something curveball in later months or years that we don't yet know? Because actually, I would hypothesize the pandemic's been very predictable since the end of January. And what I'd like to know, is there anything unusual, unexpected that we haven't yet thought about that will come to haunt us in future months and years?
And do you think if it does, that we're a year into it now, the virus has been here a year, hasn't it dished out all its surprises?
Well, we've only been with it for a year, so that's very young for a new infection. We're still learning things about measles, and HIV and tuberculosis and malaria still sometimes confuse us and surprise us. So I think we should be prepared for this is now a human endemic infection. It's not going away. And there may be, surprises coming down the track that we shouldn't get fixed in our views at the end of 2020 that this is it.
Excellent. Okay, well, I'm glad you talked about views there, Jeremy, because we're going to solicit the views of the audience now. We're going to head to our first poll of the evening. So please, again, go to slido.com, enter the event C019 if you haven't already. And we would like you to answer the following question. I'm going to pull up the poll on my phone here. My understanding of how science works has changed during 2020. To what extent do you agree with this statement? So please enter your thoughts there. And while we're doing that, we're going to carry on asking our panel what they think of the science. Perhaps I'll stick with you, Jeremy, for now. Do you think science has been used well in the battle against COVID?
I think it's been very variable. I mean, I think the most important thing is that science changes. Science is not a monolithic thing that you get to on the 15th of January or the 20th of January and it's then fixed forever. It changes. And I think one of the biggest challenges in all of this is dealing with uncertainty. And yet having to move at the pace or faster than the epidemic, and therefore having to make really big decisions based on uncertain data, but absolutely being punished if you don't make those decisions on time and faster than the speed of the epidemic. And that's been a big, big challenge for policymakers, been a big challenge for scientists.
We've got the poll results coming in. So this idea that people's understanding of how science works has changed, 34% of people agree, 27% disagree, neither agree nor disagree is 23%, and strongly agree is 8%. So let's add up all the agrees here. So agree and strongly agree is 7. So about 40% agree that it has, this year has changed things. Nicole, can I come to you, because you're a young researcher at the beginning of your career. How has it been for you being thrown in at the deep end? Because you've shifted research a little bit here, haven't you? Tell us a little bit about that.
Well, it's been a pretty crazy year, definitely. On a personal level, I guess I've never worked so hard, and I've had to balance the personal things like having young children, the lockdown affected going to school, and learning to work around that. Had a new baby in the family this year as well, so it's been a big challenge, but that's nothing special to me. I think lots and lots of people have faced similar challenges in combining work and home life. From a work point of view, it's been quite fascinating. So I feel like it's really allowed me to sort of focus my previous experience and knowledge to try to, on something really useful and really, really important. So yeah, it's been a mixture of challenging and exciting. We've been pushing as fast as we can in the lab to change the work that we were doing previously on the influenza virus to repurpose what we were doing for COVID-19, which has been a steep learning curve. A lot of fun, a lot of hard work. I'm lucky to work with a fantastic team of people and collaborators. And tell us as hard as I have. So
Nicole, what is it that you do on a day-to-day basis that is making a difference in this pandemic? How is your work helping us to understand more about the virus?
So we've always been interested in different ways to detect viruses, and we use microscopy to do that. So we had worked over the last 3 or 4 years on rapid detection of influenza viruses. And from about March time, we quickly changed tack and switched to rapid COVID detection. So we've got a great technology that's a very, very rapid COVID diagnostic test, gives a result in just a couple of minutes as a result of it. So yeah, this has really been a huge push from the people in the lab, as well as our clinical collaborators as well, and other collaborators in other labs all over the world. So I think that's another really important point as well, the huge global marathon of the scientific community and the medical community and everybody coming together to try to do something to understand and control the virus.
Right. Anne, can I ask you a question that's come in from Scott? A very interesting question. Has there always been so much conflicting data and opinion in similar situations before, or has social media just made it visible?
But I think it's really important to understand that actually, as what Jeremy said earlier, we started out with incredible uncertainty about this virus. And of course, science proceeds very often by asking a question and then trying to solve it. And very often you'll find several hypotheses often competing until you have the data to understand one way or the other, which is the likely answer. I think one of the things for me was, when I think back at the beginning, suddenly overnight we all had to become experts. Well, nobody was an expert in a sense, because we were all learning. And I think one of the things you heard is quite definite statements made, for example, about how the virus was transmitted before we fully understood the biology. So I think as scientists, it's really important to explain what we do know, but equally important to try to explain where uncertainty lies. And I think you've heard that from us all asking questions just now about what is it we want to know about the virus. And it's quite clear that there are some really fundamental things that we still don't understand. And maybe that's something we actually need to be much better at communicating with the public. I think, on the other hand, social media can also have the problem of augmenting things that just are incorrect. But equally, people may just not, we maybe don't communicate that uncertainty well enough.
John, how has the science been for you?
Well, it's been quite an intriguing time, actually, and as has been said by the other speakers, almost particularly in the spring, the winter and the spring, not a week went by that there wasn't some massive revelation about how this disease or this pathogen was operating. And that's the remarkable thing about working on a disease that nobody's ever worked on before, is that you start with knowing nothing, and then you start to find out stuff that is pretty surprising. Lots of examples. The very high level of asymptomatic disease, which came out of the ONS study, was, that was a shocker and changes your whole way of how you approach the disease. The role of the renin-angiotensin system, which is clearly going to be fundamental in understanding pathogenesis, was something else we found out about. The cross-reacting immunity, T-cell immunity between beta coronaviruses and this disease, another really interesting observation. So there's a whole list of things which just added up week after week. And I think it just showed, the pace at which the science was going on, but also how we were stripping back a much better understanding of the disease progressively all through the spring. So by the time we got to the summer, we knew a lot more, but we still there's 80% of stuff we still don't know. So
I want to stick with you, John, because we have lots coming in about the vaccinations, and obviously you've been heavily involved with the Oxford AstraZeneca vaccine. And I want to talk about the pace. I mean, you've mentioned that, the speed. Everyone feels as if they've been living at 100 miles an hour over the past 10 months or so. But the speed is one of the things that people worry about in terms of the science and the quality of the science, perhaps also the quality of the vaccine. Is there any reason why we should worry about the speed? I mean, this is unprecedented. Have we gone too fast on the science sometimes, or perhaps has the science in the past been too slow?
Yeah, so I think vaccines are a good example of this, because I think we have gone really fast. I mean, Tony Fauci, the great doyen of infectious disease at the NIH, famously said in February of this year that there would be no vaccines available to the end of 2021. And, that's a bit of a clanger, frankly. So I think it's been immensely impressive about the pace at which these have happened, but also the care that has been taken to be very, very conscious that if we don't maintain the trust of the public in the safety of these vaccines, you might as well not have them. So if you have a large percentage of the population who won't have the vaccine because they're worried about the safety, you might as well not have the vaccine at all. So I think, just having observed the Oxford program at close range, they were very careful to make sure they completed all the preclinical studies. They did it in 3 species. They wanted the primate data. They were very anxious about antibody-dependent enhancement. There was a lot of care taken there. And I think to some extent, the speed that they were able to move also reveals the slightly clunky nature of the way we used to do things. So I think we've learned that you can do things faster. So, for example, approval of vaccines. Well, you can approve vaccines faster if the regulators just move the committee times to meet the data coming in the door. If they say, well, sorry, you just missed, the committee met yesterday, well, you have to come back next month because they're not going to meet again until the middle of January, guess what? It's going to be unbelievably slow. Well, the MHRA has done exactly the opposite. They said, okay, guys, here's the data. Committee's meeting tomorrow. Let's talk about it. Let's get it done. So I think it's revealed some of the slightly sort of archaic pieces of the research governance arrangements that we've had historically.
Okay, so we've got these vaccines. They have come at us fast, but that's because people have pulled their fingers out. There's a great question from Richard Woods. how will we know if it's successful in the real world, these COVID-19 vaccines?
Well, I mean, that there's going to have to be a huge amount of post-marketing surveillance. I mean, that is clear. And I think we're lucky in the UK if we can use it properly. And that is, we do have now global GP records sitting in NHS Digital that could provide a really helpful angle on how these vaccines are performing in the real world, at least here. But of course, there are, you know, we'll have to evaluate that also in other jurisdictions where they'll be being used, and we'll have to keep a real eye out for safety signals, of which there will be some, and they'll have to be tracked down. But also in terms of efficacy, we really do need to know whether these vaccines reduce transmission, reduce asymptomatic replication of the virus, or whether they stop people from getting a sore throat and a fever. You know, these are all crucial questions that have to happen in the post-marketing surveillance space.
Excellent. Okay. Thank you very much, John. We are going to go to our next poll of the evening. So again, if you can go to slido.com, enter the code for the event C019, and you will see the second question. How likely are you to have a COVID-19 vaccine? So please answer that. And in the meantime, we will go to some of the other questions we've had. So let's see, for example, we have now, Jeremy, would you like to come in and talk to us about the messaging on the vaccines? Because we are given the impression that vaccines will end the pandemic. Is that going to be the case?
Yeah, just to pick up a little bit though on the speed as well, to add to what John said as well, if I may, which is that the other thing we should remember is that I think over the last 10 or 20 years, we've been trying to work on vaccines for diseases which are incredibly difficult, maybe impossible to make vaccines for: HIV, malaria, TB. And I think we've all got to, I hate to say it, but a little bit pessimistic about the ability to make vaccines. And this infection clearly does give you a period, we don't know for how long, of immunity after natural infection. And therefore, replicating that with a vaccine is much easier than when you don't get that sort of immunity, as in, for instance, with HIV. So I think it's a combination of factors. And also because there's been so much public funding for these vaccines, companies and academic groups have been able to do stuff in parallel rather than all in sequence. So the manufacturing, making sure there are glass vials, making sure there's distribution networks, these have all been going on at risk as the vaccines have been developed. Whereas normally a company would wait until they were sure that vaccine was going to work before they invested in that. So I think a lot of the timescale has been concertinaed in a way which is very positive, rather negative. And on the risk profile, most vaccines get licensed after about 4,000 or 5,000 people in clinical trials. These vaccines have had tens of thousands of people in clinical trials, and we probably know as much about at least the short-term effectiveness and efficacy and indeed short-term safety of these vaccines than we have done for many, many other vaccines in the past. The vaccine itself will not stop the pandemic. No, this is a human endemic infection now, and we will come to live with it as we have done with all other infections, from measles to many, many others in the past. And science is the way that we won't necessarily stop the epidemic completely, but we will then be able to live with it as we live with the epidemics that continue with measles and other infections that science has given us a route out of. But it will feel very different in 2021 and 2022 as these vaccines get rolled out.
So you'll be glad to know that on the poll, the second poll, how likely are you to have a COVID-19 vaccine? 80% of people are very likely, but that is a self-selecting audience, I suspect.
Sorry, I didn't answer that. 81%, because I'll be certainly getting the vaccine.
80. at least, and I should have said, you know, you can answer honestly. You know, we're among friends here, so if you have reservations, you can voice them. But as you say, we're not going to get back to normal, maybe for another year or two. what does that mean in terms of social distancing and wearing masks and restrictions, for example, maybe the restrictions that we've had, the lockdowns? Can you hear me?
I can answer that quickly if you want. I think it'll take a while. It'll take two things. One is, when could we get back to something called normal? And I think, and then when will we get back? Because I think there will be some scars from this pandemic. There will be a change of behavior after it. There'll be a tail to before we go back to something before COVID. And you know, when you see pictures now of people getting onto rammed tubes and trains, and you think, do I really want to go back to that? I'm not sure I do, not just because of COVID, but just because it looks pretty dodgy to me. So I think it'll take a while for people to relax and think it's safe, be over and beyond what may be the scientific justification for those.
And it's really interesting because actually there are probably, it's 5% of the audience are either unlikely or very unlikely to have it, and 7% are undecided. So that's really interesting responses. And I want to take some more of your questions. So here's a really popular question. I'm not quite sure who should take this, maybe Anne. How should we counter the anti-vaccine lobby?
Oh, that's a really interesting question, and I think it's a really important actually to be very clear about the data from the vaccines, the preparation that's gone into them, and sort of really being absolutely clear with the public what we do and don't know about them, which I think is you know, the long-term impacts and so on. But I think there's also a question about how we better understand how data about vaccines is transmitted on various platforms, and how we try to make sure that there is clear and open information on a lot of social media platforms. But also we have to think carefully about when really false messages are transmitted on platforms. So there's a very big role here, both for the if you like, the mainstream media, but also a better understanding, I think, of how, in fact, how misinformation actually is transmitted, and how we better counter it if people are making decisions on misinformation. I mean, people will always have to make their own decisions about whether or not they accept a treatment or a vaccine, but that should be based on I think, you know, the best and most balanced information, which we as scientists have a duty to make sure we communicate well.
John, I want to bring you in for one of these questions, because Jeremy was talking about, you know, we don't quite know maybe the very long-term consequences of this, and actually quite a lot of questions are coming in on that. So there's a question from Alton. How do we know the COVID vaccine won't have any serious side effects in the years to come? And might that be something to do with any long-term consequences that we don't know about of the virus? Is that possible?
Yeah, so in terms of side effects from vaccines, the vast majority of them tend to occur in the first 2 or 3 months. It's not universal, but most of them do. The narcolepsy problem obviously appeared 6 months in, but you can usually detect stuff pretty early on as to what's going on.
Sorry, what was the narcolepsy problem?
Well, with the flu vaccine in 2013 or 14, they used a very powerful adjuvant, and they rushed it through, of course, because there was real anxiety about the swine flu epidemic. And it emerged that there were a small number, but still significant increase in the frequency of narcolepsy, found originally in Sweden, because they have such good records, but also proved in the UK. And that I think there's been quite a lot of work to work out how and why that happened. But you know, it is not true that all vaccines are completely safe. And I think if we say that, it's a real mistake, because I think we have to be truthful and open about stuff that has happened. Most of the consequences of vaccine toxicity have been relatively apparent short term. Again, there was a small but significant number of people with Guillain-Barré syndrome associated again with flu vaccines historically, and that's something that we watch out for pretty assiduously. So we're aware of stuff that happens. Could there be something completely out of the blue? There could be, but I think, as Jeremy has said, we've had an enormous number of people now vaccinated with this. And the vaccine started, remember, in April. The Oxford vaccine was the first to go into people, and it went in, I think, the first week of April. So, we're approaching 9 months of exposure in people, and we've been watching all the time. So will something pop up 5 years from now? Well, it might, but it's pretty unlikely in my view.
And is it the case, do you think, that, for example, Nicole, do you think it's just a case of we have to accept that there is this new risk that we're living with, and we have to make a decision one way or the other? The risk of the vaccine must be balanced against the risk of the disease.
I think it's a question of having as much open information out there as possible and as accurate information out there as possible. So it comes down to a communication thing. And then once people have all of the most up-to-date and accurate information at their disposal, then they can make a decision. And I think it comes down to weighing up the risks of a very, very tiny risk that might be associated with vaccine use compared to, for example, something like long COVID, which we haven't touched on, but which is one of the long-term effects of COVID-19 that isn't necessarily associated with elderly population, can affect people of any age. So I think once that information is properly available and people can understand and digest it, then I think it makes the choice much easier. I'm
really glad you talked about long COVID, Nicole, because that is one of our top rated questions from Maddie Corper. Please, can you talk about long COVID? Any idea of the pathogenesis? So what is this syndrome that seems to affect so many people and for such a long time?
I think the short answer is not completely sure yet. So this is whether it's a single syndrome or multiple syndromes, but this is something that does affect people longer term. So it can start a few weeks after you've had COVID-19, but it can also start much later. It doesn't seem to be linked to how sick you've been. So it can happen even in people that had very, very mild symptoms. And as I said before, it can also affect people of any age group, even young people that generally have mild or asymptomatic cases. So there's still a lot of work to be done, a lot of questions to be answered. Yeah.
That's the tough thing, isn't it, about living with this new pandemic? There are so many questions and not enough answers, as we were talking about at the beginning. So we really have great questions coming in. Please come and vote for your favourite questions as well, and we're trying to get through some of them. And I want to go to the next poll, I think. And we still haven't really moved very much on the how keen are people to have the vaccine. That came out as about 4 out of 5 are very keen to have it, which is great, but obviously there's more work to be done. So the third poll of the evening is the following question: do you think the world is more prepared now than it was for future pandemics? And again, if you go to slido.com, enter the event code C019, and then you can answer the poll and you'll be able to see what everyone else is answering too. So I've pressed agree for that one. I don't know what you think. Who would like to come in on that one? Whether we are more prepared. Perhaps you, Anne. What do you think we need to do now to guard against future pandemics?
Well, this is something that's been on the agenda actually since the flu pandemic, where we talked about trying to be better prepared. And I think one of the things that we tend to be doing is always preparing for the last pandemic, rather than the one that we're in now. And we have to be vigilant on things that are just going to come out of the blue and completely different from the last thing we saw. We saw that with SARS, and we've seen it with a whole range of newly emerging infections. So clearly you really do have to have a strong international system of surveillance, and some of that is actually the laboratory capability, but there's a lot of other capabilities that are required, which is strong, public health systems on the ground that pick up weird events going on. And that includes, the sort of thing that picks up an early Ebola outbreak, and which works very closely with communities to get that information through. So strong surveillance systems, but also strong international systems, which are built on the idea of open data. It's been very important that, for example, when an unusual situation emerges, there's rapid collection of data, rapid sharing, say, for example, of sequence and so on, which is incredibly important for the development of this vaccine, and investment in international structures to enable us to work more closely together in the future. In the UK, I think we really do need to build that capability in infectious disease surveillance and public health responses to have that capacity going forward. And we need to use modern techniques as well of kind of using a whole range of electronic methods and data collection to pick up unusual events in outbreaks, for example, through internet searches and those sort of things, and other methods of environmental sampling in hospitals and other environments for unusual cases. You said that you're talking about international cooperation. I'm quite interested to hear what Jeremy feels about international cooperation. To some extent, in this pandemic, we have been very concerned with our own local epidemics in our own countries. And sometimes I think that's we haven't always had as much international discussion as we might have done. That might be unfair, and Jeremy knows better about this than I do, but we really do need to, I think, continue to build those links and openness. Jeremy, let's bring you in.
Yeah, a few things. I agree with what Anne just said, but a few lessons of the last sort of 20 years, because it does go back 20 years, this. The world's had enough warnings since Nipah outbreak in Malaysia in 1999, and a few reflections on that. Firstly, I think you have to take warnings seriously. Because we will face, because of the nature of changing ecology, urbanization, trade and travel, we will face more frequent and more complex epidemics in the future. And that's what's happened in the last 20 years. Personally, and I come from a background in emerging infections, don't focus all your attention on preparing for epidemics. Because if you do that and you don't have an epidemic in the next few years, inevitably policies change, funding changes, and it drifts away. So if you want the best way of preparing for epidemics, prepare a public health and surveillance system that is giving you utility and benefits every day, every year, and doing what you do. And there's so much more that we could do on that, and then have the surge capacity to be able to respond to an epidemic. And it's no surprise that Singapore, Hong Kong, China, Vietnam, indeed, have responded better this pandemic, because frankly, they've experienced that in the last decade, and they had the systems to respond to it. And the last thing I'd say is, don't think you can turn these systems on the day you need them. You can turn them on if you've invested in them for the years before an epidemic happens. And if you didn't invest in them, they won't be there when you need them. And that's a crucial policy decision, I think, that has to be made in the coming years when we learn the lessons from COVID-19.
Very much agree with that, Jeremy.
Can I ask you, Jeremy, because you're on SAGE and you're government advisor, you've been at sort of really at the sharp end of feeding the science into the policy decisions. Do you think that come the next pandemic, that process of feeding science into policy will change? I mean, we had one of the questions here, which is really interesting, actually, from Helen Jones. Did government science advisors misjudge appearing alongside politicians in the infamous daily briefings and claims of following the science? And what does this mean for public trust in science? And should there be greater distinction between scientific evidence and political decisions? Did some of that get muddled in this pandemic, do you think?
Yeah, I think yes, of course it did. But I would just like on the record pay tribute to two people that I think have borne the brunt of this, Patrick Vallance and Chris Whitty, who I think deserve enormous credit for the way they've conducted themselves over the last 9, 10, 11 months under enormous personal and and a pressure that has gone well beyond what anybody, frankly, should cope with. I think there will have to be a review. I mean, SAGE has never sat for this length of time before. SAGE has normally been there for an emergency. It happens, it goes away, and SAGE is disbanded. This has gone on now for 11 months, and that's taken a huge amount to keep going. I think there does have to be a separation, and people need to appreciate that scientific advice is scientific advice. And ultimately, the decisions, tough decisions on lockdowns, lifting restrictions, etc., those are political decisions. And I think we all need to respect that. And it can't just be one bit of science or one discipline that is feeding into that advice. It is politicians then have to step back and say, what do we have to do in the round in all of this? And inevitably, sometimes scientific advice and political decision making will be in tension and pull in different directions. John,
what's your experience here? Yeah, you want to come in?
So I agree with all that. I think I think one of the serious issues that we've had to deal with is that, you know, nobody either in the scientific community or in the political world has ever dealt with something like this before. So it was bound not to be perfect. First of all, the scientific advice was largely going to have to be cooked together at the beginning, because we didn't really, you know, what do you do the modeling on? There was no data. So, you know, you end up with, I think, lots of stuff which maybe wasn't as good as it would be in peacetime, as it were. And similarly, you've got politicians who, you know, get elected and are sitting politicians who have no experience of anything like this at all. So don't be surprised if they don't get everything right. And I think that there hasn't been enough generosity in the system to acknowledge that both the scientific advice and the political judgments were inevitably going to be less than perfect, because nobody's ever done this before. And I just, you know, I think that now that's not an excuse for, you know, doing things badly, but on the whole, people have been trying pretty hard to make the right decisions based on whatever data they've had. And I think we've got to accept that. And it was never going to be perfect. And to be clear, it hasn't been perfect anywhere. The only places where it's been better than us is in places where societal rules have allowed them to take a much more authoritarian view over managing lockdowns and managing the population, and in places which have recently experienced, you know, either a SARS epidemic or another epidemic. You know, South Korea, Singapore, they've done pretty well, but even they have not done perfectly. You know, it's just, this has been hard.
So they've learned from their pandemics. And interesting, the poll suggests about half of the people agree. So 49% of people who have participated agree that the world is more prepared now than it was for future pandemics. That's interesting. So kind of half of us are convinced, maybe half not. But I want to go back to this idea, though, that it's not just, as you said, Anne, the surveillance, and you've hinted at this as well, Jeremy. It's actually decision making, isn't it? It's about acting on the science, acting when you see things, and actually how do we become perhaps better at, maybe it's having the systems in science that allow you to act faster.
Actually, if I can come in that, you know, I think one of the biggest challenges has been, on one hand, the science, yes, and then the science is the science, and the advice that then has to be turned into policy. I think one of the biggest challenges has been delivery on, you know, major programs, which under normal circumstances, you know, if you were rolling out very big programs, you would test them out, you would evaluate them, you would tweak them, and then you'd roll them out. Now, in reality, we've had to do all that at breakneck speed, and a lot of the things, arguably, that haven't worked out right have been because we haven't had the time to have those test beds and get all the logistics right. That, I think, that's been one of the biggest challenges we've had, and we should reflect on that in due course. Yeah.
And do you think the science that will come will be better in the future as a result of what we've learned during this pandemic?
I think
You'd
there's
certainly
something,
hope so, wouldn't you?
I think there's something to be said for the collaborative nature of the scientific response to the pandemic. So there's been an absolute explosion in the scientific literature, for example, and a lot of that has been in open access sources, open access databases, preprint servers, for example, so that the information gets out there and is available to people as early and as widely as possible. So hopefully that's something that has changed and will continue to be so going forward.
But Angela, if I could just come in.
Do, Jeremy, come in.
I hope it's not my dog that's barking. I agree with what everyone has said, but I do think we have to be a little bit more critical. I mean, Western Europe, North America, had two major waves of this epidemic. One in March, April, May, when we perhaps didn't know quite what was happening in January and February, and you could, if you were charitable, say we couldn't quite have got that right. But then we had the summer, and then we faced an autumn and winter wave, which we knew was coming.
Yep.
And we didn't learn sufficient lessons from the first wave and get in place enough for the second wave. And you can see what's happening in the United States at the moment. It's going in a really difficult place, and Europe has been through a second wave. And I think when you learn lessons, it's not just learning for the future, it's learning for the current pandemic as well. And we've got to look at why we didn't use the summer better and learn those lessons and prevent what has been a really difficult second wave in the autumn and winter.
Can I bring in another question here? A really good question from Tessa Finch, which speaks to this idea of the constantly evolving science. So why is the need for good ventilation not expressed louder, given that the science now indicates airborne transmission via aerosols in the breath? Now, it's interesting because I saw this on Twitter today. I think it was Kimberly Prather, the aerosol chemist in the States, who's done a very good job of kind of driving the acceptance of aerosol transmission. And she was making the point that people seem reluctant to acknowledge this, perhaps because of the implications for indoor dining, the indoor economy, I guess. Would you like to comment on that? Why is it that aerosols are not kind of promoted as being an issue as much as they could be?
Well, I can have a crack at that. It's because the data is not that clear. I mean, it's fine. Some of the data is fine, but if you look, for example, at transmission in airplanes, cabin crew don't have an increased risk of developing this disease, which is pretty odd if it's an aerosol spread disease.
But don't they have a very specific filtering system in airplanes?
Well, yeah, they do. But you've got a lot of people breathing into the air, and I think as you know, in the original SARS epidemic, there were on aircraft with had index cases. There were people infected miles away in the seating pattern. For this disease, it hasn't happened. It's just the people sitting next to them that get infected. So I think it's a plausible hypothesis. I'm not sure it's proved.
I think that any transmission experiments are just inherently difficult because it's very difficult to do a completely well-controlled randomized trial on it because you might potentially expose people. So a lot of what we know about transmission in respiratory viruses is just based upon, on I guess, good hygiene practice. We know that washing hands and wearing masks can help reduce transmission, and a lot of common sense, I think, as well.
Couldn't we say that also though for masks, that actually there is a lack of really good randomized, gold standard evidence on masks, but we now mandate them on public transport and so on in indoor settings. So it's is this an illustration of how we're trying to sort of find our way in the dark in the science?
I think mask wearing is one of the areas where we've come a really long way, and we've learned a lot, and the science has progressed a lot over the course of the pandemic. So there is now really increasing evidence that they can help to prevent transmission. So.
This is a good time to go to the same question that we asked at the beginning of this event. And I think you know the drill by now. You go to slido.com, C019, and please answer the following question, which is, in one word, how would you describe the scientific response to the pandemic? So we want to get an idea of how everybody has processed what they've heard. You know, perhaps you might feel differently now, having heard from some of the scientists right at the sharp end. So let's see, I'm going to, what would I choose? In one word, how would I describe the scientific response to the pandemic? I'll go with fast. Oh, rapid. So here we go. We now have our SoundCloud coming up again. Rapid, we've got an outstanding, a good, fast, practical. It's changing all the time. You'll be able to see it yourself if you go on Slido and enter something. Hubris, incredible, unsatisfactory, heroic, fragmented, all words that I think all of us would recognize here. So I want to say we're coming to sort of the last few minutes now. And I wanted to ask the panel what you think the outlook is going to be like for the next, maybe it might be the next 6 months, maybe the next year, 2, 3 years. Anne, what do you, how are we going to be living with this virus in the next, you know, in the future?
Well, I mean, I think it's absolutely right that this virus is going to become endemic in human populations, but I very much hope, really hope, that all these vaccines, we've got one coming through now, we've got the results from the others, that we will really see a major vaccination program which will have high uptake, and we will gradually see in the coming months not only more people being protected, but a gradual slowing of the virus transmission. But I hope we don't just all give up on the social distancing and the behavioural interventions, which we haven't talked about, but actually, to be honest, have been our only defence so far. And we haven't talked at all about behavioural science. And the issue about communication with the public, I think, is a hugely important one, which we're going to have to maintain, both for vaccine uptake and for maintaining these hygiene measures. I hope we will learn, as much of Southeast Asia done, and the Japanese learned 100 years ago, that we will have to continue to be more careful about respiratory hygiene. I think we're going to have to think a lot about reducing transmission in hospitals and care homes, which we haven't talked about, which remains a big issue because of the way these viruses are transmitted. So I don't think anything's going to rapidly change overnight, but I am looking forward to a very much better year next year. But I accept we've still got a tough winter to get through. And I'm hoping that we will continue to take those learnings forward as we recognise that this virus is still going to crop up, as all the other endemic viruses we've been talking about have continued to persist. In exactly what form, I don't quite know, because we have all the unknowns that we started with, and how long we'll get immunity from this vaccine, and if we're going to have to revaccinate and things like that. Those are all going to be very big questions for us to answer.
Do we think that the virus is going to evolve in response to vaccines? Who would like to come in on that? John, perhaps?
Yeah, so I think it's quite likely it will evolve. As you know, it's evolved it has evolved a bit in the last 10 months. The selective pressure from vaccines is likely to push it to evolve a bit faster, and we're going to have a really good program to look at the evolution of the virus in the face of a strong selective pressure against it, because that's a sort of sitting duck for mutation and variation. So I think we'll see it. Whether it's a catastrophic, there's always a balance between fitness and pathogenesis, and it may well be that in introducing new variants, you actually carries a fitness effect, and as a result, you don't get a lot of increased pathogenesis. But I mean, who's to know? We just need to be on the alert for it.
And Nicole, what about reinfections?
Yeah, I think that's another hugely important thing that we have to look out for. So there's still, again, lots of questions that need to be answered about reinfections, how common they are, if whether there's conflicting evidence of whether, if you do get it a second time round, whether you're going to be as sick as the first time. There's evidence of both, actually. So some people that get, completely asymptomatic second infection, and then other people that have had it much more severely. So there's still lots of unknowns there as well. And I think that's really important, tying back to the vaccine as well. So we don't know how long immunity will last once you're vaccinated. And I absolutely agree with what both Anne and John were saying, that we need to have a really great system in place to encourage people to be revaccinated. It might end up having to be an annual vaccine, for example, and people are going to have to keep coming back and having it year after year. So yeah, I guess there is light at the end of the tunnel, as they say, but it's going to be quite a long journey.
And on that, I should say that we've got our top-rated question. Well, actually, one of our top-rated questions from Faith Mortimer here. What work has been carried out using the vaccine on immunodeficiency suppressed people? I don't know if that's probably one for you, John.
Yeah, the answer is none. So, there's a huge amount of work to do to understand response in immunodeficient people, in people with cancer, in people with lots of other chronic renal disease, where their immune systems are innately different than normal populations. So that is all still to play for. And in fact, I'm not sure how much pediatric data there is available. That will also probably require some new studies to try and evaluate it. So, the vaccine thing is great, but we're at the beginning of a pretty long journey to understand it better.
And I guess that just means that all of us will be experiencing the pandemic in very different ways, won't it, as we go forward? Because I'm looking forward to getting the vaccine. I'm low on the priority list, but I can hold out to the light at the end of the tunnel.
I think that one thing we haven't mentioned, and I know that Jeremy's spoken about this in the past, is also the global access to the vaccine as well. So I guess we're only as well vaccinated as the least well vaccinated country. So making sure that there's equitable access to everybody for vaccines is going to be really important as well.
I think that's a great way to end. I'm so sorry, but I think we're going to be out of time now, because we've covered so much ground, but as with all good things, they must come to an end. So I would very much like to thank our panelists, Anne Johnson, John Bell, Nicole Robb, Jeremy Farrar. Thank you to all of us who've joined in this evening. I'm sorry if your question wasn't answered. We had so many good ones, but I hope you continue to ask them and we get more questions and answers soon. Continue the conversation on Twitter if you can, on #COVIDScience, use that. Please do take a few minutes to complete the evaluation survey in the YouTube description. And I'm also been asked by the Royal Society to tell you that the next event in the COVID-19 series will be streamed live here. And it will be on Thursday, the 28th of January, and that will be at 6 p.m. and specifically on vaccines. So if I've ignored your vaccine question, it wasn't deliberate, but there will be another event to come. And now I want to say thank you very much for joining us, panelists and audience, and good night.